thank Sharon for inviting me to give this lecture and for organizing this wonderful meeting. So when we treat CP patients, when we treat spine deformities in CP patients, one of the crucial questions is whether or not we should include the pelvis into the fusion or not to include it. So the question is to fuse or not to fuse. Cerebral palsy is a non-progressive encephalopathy characterized by lack of muscle control and increased spasticity with variable mental retardation. The incidence we know is 1 to 5 of 1,000 live birth, and it's a little bit more in males than in females. The incidence of scoliosis in CP patients varies from 21 to 76%, and the progression is highest during the adolescent growth spurt. And we should always remember that it's not idiopathic scoliosis, and the progression can continue after skeletal maturity because the disease continues and it's a lifelong problem. And the incidence and severity of scoliosis is mostly related to the degree of the involvement of the CP. We know the classification of the deformity characterized into two groups. The group 1 is the one that doesn't have pelvic obliquity, and the group 2 is the one that have pelvic obliquity, and it can be either a long C shape or just focused on the lumbar area. And also we should always see the sagittal profile of these patients because it is also a very crucial and very important part of the deformity. When we have a patient with CP and pelvic obliquity, we should always assess whether or not the pelvic obliquity is due to the spinal deformity or is it due to the hips or the hip disease, or it's a combined situation. And this is done by mostly by physical examination, placing the patient on the table with the pelvis and the legs outside of the table and doing abduction and adduction of the hips and seeing whether you control the pelvic obliquity or not. If you control it, then it means that it comes from the hips. If the pelvic obliquity remains, it means that some part of it at least is due to the spinal deformity. So the indications for surgery in CP patients with scoliosis are to avoid curve progression, increasing pelvic obliquity, the loss of coronal and or sagittal balance, costopelvic impingement, as you can see on the picture on below, causing pain, skin ulcerations, and high diaphragma and respiratory distress, and causing the patient even eating disorders. The goals of surgery are to achieve a stable, solid fusion and to have a compensated spine with a torso balance over a level pelvis, allowing a brace-free, balanced sitting position. The aim is to reduce pain, to improve quality of life without decreasing the preoperative motor or sensory function of that patient. So why should we include the pelvis when we treat these patients? Is of course to try and assure that a single operation will achieve all the goals mentioned, avoiding the possibility of further future progression of distal deformities requiring revision surgery, and fusion down to the pelvis, according to some articles in the literature, does not compromise the patient's ability to ambulate. This is a paper by Freeman Miller's group, published in Spine, and they claim that it didn't change the ability of the patients to mobilize. On the other hand, why not to fuse to extend the fusion to the pelvis? Well, we know that extending the fusion to the pelvis increases the complication rate. It's technically demanding due to the pelvic asymmetry. As we can see on the CT scan, these patients have asymmetrical pelvic. It increases the surgical time, increases blood loss, more extensive dissection, creating a deep dead space, and then the end result is these patients, when you extend the surgery to the pelvis, the rate of infection is much higher. The lumbar sacral articulation is normally very a stable joint, and by this, if you spare the pelvis, a stable L5S1 articulation allows the correction of pelvic obliquity and may improve the mobilization of the patient. This was an article by McCall and et al., published also in Spine, that he advocated not to go to the pelvis in order to improve and to maintain the lumbosacral and sacropelvic joints, and his outcomes were comparable without increasing the pelvic obliquity afterwards. So other clear guidelines whether or not to include the pelvis or not? The short answer would be no, there aren't in the literature, if you see. Traditionally, you should almost always extend the fusion to the pelvis in GME-FCS patients level 5. Almost never extend the fusion levels to patients with GME-FCS levels 1 and 2. So the big question is what to do with GME-FCS 3s and 4. And this is actually the most debatable, because these are patients that if you do a mistake during surgery, you can make them wheel-bound ambulators because of the surgery. So when can fusion to the pelvis be avoided? If you gather all the literature and a little bit of experience, then if you have a small pelvic obliquity of less than 10 to 15 degrees and it is still flexible, when you have a good sagittal balance, when L4 or L5 are without any rotation, and when the pelvic vertebra is in line with the low lumbar spine, and patient who powers gait through the lumbar sacral junction with significant lumbar fixation and extension of movement. So this is why some of these patients, it's very important to send them to a gait lab before performing surgery. I'll give you some short examples just to prove what I think. So this is a patient with a mild pelvic obliquity that is reasonably flexible, if you can see it on the traction films, and you can balance it, and with no rotation of L4 and L5. So in such a patient, and a rather good sagittal profile, so in such a patient you can spare the pelvis and end the fusion to L4 or L5 because he's an ambulator. Another patient, once again, you have a pelvic obliquity, but if you see and you notice that L4 and L5 are with almost no rotation, which means that they are not involved. And if the pelvic, and you see that it's a partial ambulator patient, so in this case, once again, you can spare the pelvis and go down to L5 and maintain level pelvis without fusing it. But don't forget the sagittal profile. If you have a hyperlordotic patient, then you have to go and fuse him to the pelvis, because otherwise you will maintain an anterior pelvic tilt and it will make life very difficult for this patient to ambulate. Okay. Once again, you have a lumbar curve with a pelvic obliquity, but a hyperlordotic patient. And this patient, once again, because of the sagittal profile, should be fused to the pelvis and not to spare it. Otherwise, you will have an anterior pelvic tilt at the end. But also, it's not only the hyperlordosis, it's the hyperkyphotic patients that you should consider also, because if you will correct the thoracolumbar hyperkyphosis as seen in this patient, without fusing her to the pelvis, she will be unbalanced. And that's why that's another indication to go and fuse her to the pelvis. So in conclusion, the objective of scoliosis surgery are to achieve a well-balanced spine over a level pelvis and preventing complications associated with progressive curvature. Most patients will require fusion to the pelvis because, as we saw, most of these patients, the scoliosis is according to their functional level, and most of these patients will be GME-FCS 5s, and that's why you should go to the pelvis. but fusion to the pelvis increases complications, and the dogma that all CP patients should be fused to the pelvis should be questioned on individual basis according to the gait patterns, to the magnitude of the pelvic obliquity, and to the sagittal plane. Thank you.